Now, another celebrity that we have here, um, Biykem Bozkurt. Biykem is uh, senior dean as of day before yesterday of Baylor, and also the just immediate past president of Heart Failure Society of America, and editor-in-chief of Jack Heart Failure. And believe me when I say that every Tuesday, I am so fortunate to be on that call and learn from her. So Biykem, thank you, thank you, thank you. And so Biykam's topic is time to erase boundaries between heart failure with reduced versus preserved ejection fraction. At least therapeutics suggest that. Oh, sorry.
Dr. Narula is too kind. It's a pleasure for me to be here and be in the presence of colleagues who I respect. So this concept of what to do about ejection fraction is commonly discussed. And we have seen a very helpful presentation from Dr. Kusumoto about how the paradigm is changing as to what we think about the ventricle. So the first thing I'm going to talk about is EF is not everything. And treatment right now straddles different components of ejection fraction. You astute clinicians always knew that, but we guideline writers were classifying EF. So in the new 2022 AHA, ACC, HFSA heart failure guidelines, we layer the EF further than the classic HFrEF, heart failure with reduced EF, and HFpEF. Why did we do that? We have more data. So there is a middle component called mildly reduced, which is specified as EF between 41 and 49%. So low EF is less than 40, preserved is more than 50, somewhere in between, mildly reduced is 41 to 49. And this is going to evolve further, partly because the evidence, the clinical trials, the way they are designed, is going to address different phenotypes. And we have heard earlier about genetic etiology. Specific etiology is mattering, and therefore our definition and or our treatment not solely being dependent on an EF phenotype. There's more to the ventricle than just the EF. You all know that. One other important thing that we address in the guidelines is on the right side, the trajectory. What happens to the EF when you remeasure it, right? So what happens if the EF improves is not the same thing as preserved. So we call that improved EF, heart failure with improved EF, partly because I'm going to show the data. We want you to continue the treatment with GDMT in most of those patients and not withdraw treatment unless they're truly curable, such as tachycardia-induced cardiomyopathy or others. Now let's talk to the topic that I was assigned. Do we have evidence for benefit from certain agents that work in the heart failure spectrum regardless of EF? Yes, the evolving evidence with sodium glucose cotransporter 2, SGLT2 inhibitors right now straddle different EF phenotypes. The first evidence came from the diabetes trials. So these were conducted in patients with diabetes and cardiovascular risk. All patients with diabetes have cardiovascular risk. We recognize that, but these were a little bit higher risk. And what they show concordantly is, if you look at those curves, I'm going to be showing some curves, but I want you to just look at the overall gestalt. About 30% risk reduction for future development of heart failure. So in the aftermath of these diabetes trials, SGLT2 inhibitors gave us a signal that they're actually heart failure drugs. They prevent future development of heart failure. So this is pre-heart failure, preventing heart failure. In the aftermath of that, because the heart failure doctors took a clue, and clinical trials were designed this time in reduced EF. Two major trials with dapagliflozin and empagliflozin, same signal, significant risk reduction in the order of about 25% risk reduction, this time in cardiovascular death and heart failure hospitalization. You're going to hear me talk about that magical outcome that we like using in heart failure, cardiovascular death and heart failure hospitalization, because we want to look at both the morbidity as well as mortality. With these two agents, there's significant benefit. The other important thing I'm going to emphasize on this slide is separations of curves start early as within a few weeks, as early as 30 days concordantly across all trials, and in the HFpEF trials as early as 2 weeks. Then came the heart failure with preserved EF trials with SGLT2 inhibitors. Before we wrote the guidelines, we had evidence from one trial, the Emperor preserved with empagliflozin shown on the left, and on the right side, the second trial that came after we wrote the trials, from DELIVER-HF with dapagliflozin, with those two agents, again, showing a significant improvement, the same message of benefit with SGLT2 inhibitors now in EF over 40. Who are the patients with EF over 40? Are individuals with, remember, mildly reduced EF, 41 to 49, as well as preserved EF with EF over 50. In the aftermath of these trials, there was a question, what is the ceiling? Is there a ceiling? But we'll go over that in a minute. So the current evidence of what we know with SGLT2 inhibitors is that they work in pre-heart failure in individuals at risk, as well as with individuals with structural abnormality, as well as reduced, mildly reduced, and preserved EF. I didn't show you data from two additional trials, namely MPulse and Soloist, showing safety and efficacy to start the SGLT2 inhibition before discharge for hospitalized heart failure patients. What they showed was it was safe and effective. So the last bucket is you can start it in even acutely compensated heart failure patients. So the whole spectrum right now is covered with SGLT2 inhibition. So what is not covered, which is coming, is post-MI, acute post-MI within 7 to 14 days. So that's the group of individuals that we're going to be hearing more. There are 3 big trials being conducted, both with those two agents as well as others, looking at the safety and efficacy of SGLT2 inhibition. And if we have that, the benefit, a whole spectrum of benefit will have been formulated for SGLT2 inhibition. And the concept of how high of an EF is too high, or is there a ceiling to the benefit? What about EF of 65? What about 70? We always say those individuals are different types of patients because in the clinical trials, hypertrophic cardiomyopathy and infiltrative, i.e. amyloid and others, are usually excluded if you know it, okay? So this was an important signal for us, partly because I'm going to show some subgroup analyses, and bear with me. If you look at the subgroup analyses of EF from the Emperor preserved, this is with empagliflozin, that p-value over there on the right side represents whether there is significance in heterogeneity in the populations according to EF. That p-value is not significant. What it says is those confidence intervals that you see as those lines, giving the impression that lower EF, the higher the benefit, or the higher the EF, lower benefit, is actually not significant. But this sort of gradient created a concern or question in the clinicians' minds, how about EF over 60? So in the aftermath of this Emperor preserved trial, we started asking this, and they did further studies. So the Emperor investigators actually combined, remember there are the reduced EF as well as preserved EF trials, they combined it and they called it Emperor pooled. And their EF analysis said, well, over EF 65, probably the signal does not show benefit. So this was in the aftermath of the Emperor preserved. Maybe there's a ceiling. But there's always a but in statistical analyses. When you look at the continuum, EF in a continuum analysis, not as a classes according to buckets, it doesn't show any heterogeneity. Though the spline curve analysis suggests maybe there is a ceiling. If you were to have maybe a larger population towards the higher end, maybe there is a ceiling. So this was in the aftermath of that Emperor Preserved trial. Remember, I told you the second trial, Deliver, dapagliflozin, they actually recruited a large population of individuals on the high end, and also included patients with improved EF, and pre-specified their subgroup analyses. What does it show? If you focus on the top, all EF subgroups benefit. There doesn't appear to be a signal for ceiling, at least with dapagliflozin. And on the lower panel, improved EF, there's significant benefit. So in essence, this adds to the further narrative that in the spline curve, the continuous EF analysis on the right side, there doesn't appear to be ceiling, at least from the Deliver heart failure trial. And it looks like it's safe as long as you know that they're not hypertrophic cardiomyopathy and amyloid patients, which were not included in the trials. Right now, across the whole EF spectrum, SGLT2 inhibitors appear safe and efficacious. And this is the very recent meta-analysis that just got published showing the benefit across all EF classifications when you combine these two agents from two large-scale trials. So in essence, back to what I had stated, we do have evidence of benefit across all EF, across all phenotypes in heart failure once you know it is heart failure. The concept that gets raised is, shall I just initiate this agent for any patient who seems to have symptoms of heart failure? Symptoms of heart failure is not adequate to ascertain the heart failure diagnosis. Somebody with shortness of breath and edema could be volume overloaded from liver failure, from kidney failure, from a variety of other volume overload states, as long as you can ascertain the heart failure diagnosis. And in our guidelines, what do we say at the time of heart failure diagnosis is do an echo. Why do we say do an echo? And I'll show a slide related to that. We never look at EF in isolation. We look at the valves. We look at whether the wall motion, we look at the etiology to see what else we're going to treat. We clinicians never treat EF alone. The guideline writers catalog the treatment strategies for trial design matching to the recommendations according to EF. I know you will never practice with EF alone, but I know this narrative of is EF not needed to treat or initiate the SGLT2 inhibition. As long as one is certain this is heart failure, may not be needed. I just heard from a European colleague saying, well, echo is cheaper than NT-proBNP in Europe, and therefore we do echo rather than NT-proBNP. I don't say you have to do one or the other, but as long as you have objective evidence of attribution of symptoms to cardiac abnormality as corroborated by elevated filling pressures, which is the new universal definition of heart failure, you can treat heart failure. The second concept I'm going to focus on, now we're going to move away from SGLT2 inhibition and other agents. Do we have evidence that all other agents work all across EF phenotypes? The answer is no. It's simple, straight no. Beta blockers, shown on this slide, don't work in heart failure with preserved EF. There's no evidence that they're beneficial for the indication of heart failure. We do recognize majority of our patients with HFpEF are on beta blockers. If you look at the clinical trials, 80 to 90% of HFpEF patients are on beta blockers. Why? They have ischemic heart disease, they have atrial fibrillation, and they need rate control. So for other indications, we recognize its use. Left slide is a big patient-level meta-analysis demonstrating that on the higher end of the spectrum, there's no evidence of benefit with beta blockade for heart failure indication. On the right panel is a TopCat trial, if anything, is showing a signal for worse outcomes for heart failure hospitalizations for HFpEF with beta blockade. So in the guidelines, you will not see beta blockers as a recommendation for heart failure indication in HFpEF patients, in patients with HFpEF. So beta blockers, not across all spectrum. How about ARNI? The large-scale Paragon trial that looked at overall NT-proBNP levels, quality of life, and on this slide, you're seeing the cardiovascular hospitalizations as well as cardiovascular death and heart failure hospitalizations did not reach the clinical endpoint significance for cardiovascular death and heart failure hospitalizations, improved quality of life, and said there's heterogeneity for ARNI benefit. The lower the EF, the lower portion of the slide, EF less than 57 benefited, but not more than 57. And creating this gradient, the lower the EF, the higher the benefit is. With this, FDA gave the indication for ARNI all the way up to normal EF, but not above normal EF. Okay, so there is a gradient to ARNI benefit. There is no benefit from beta blockers in HFpEF, and other post-hoc analyses with MRA, mineralocorticoid receptor antagonists, named spironolactone on the left, ARB in the middle, ARNI in a continuous EF spline analysis. What do we see on this slide is these agents, by post-hoc analysis, ARNI, ARB, MRA, seem to work all the way up to normal EF. The benefit is higher the lower the EF is, right? But no significant benefit on the higher end of the spectrum. So that's how we formulated our recommendations in the guidelines. These are post-hoc. The only prospective randomized clinical trial demonstrating benefit in HFpEF right now is SGLT2 inhibition. Another comment, EF matters for device indications. We just heard about it. So we will need to re-embrace and look at the EF at the time of the device indications, and that's important. And EF will matter if we have treatment targeting contractile performance. This is not an FDA-approved drug, omecamtiv, that was studied in a study called Galactic-HF. Did reach the significance for the primary endpoint of cardiovascular death and heart failure hospitalization. This is a cardiac myosin activator, okay, and improves the contractile performance. And as you can see, there is significance, though the relative risk is modest, the absolute benefit in the sicker patients, especially in lower EF, is higher. It's suggesting heterogeneity with this agent, saying the lower the EF is, the likelihood of improvement. What does this mean? We may have add-on therapies in the future that may be working for lower EF patients. This is not FDA approved, but close. And again, in their analysis, that's famous spline analysis on the left side, showing that the treatment effect is larger the lower the EF is. So there will be certain agents that may work the lower the EF is. EF itself has never been a perfect solution. I don't need to be telling you this, but it is the practical, available solution that we have. It is not a definition for heart failure. It helps us re-stratify and helps us in the context of other variables to tell us what is the cause, what is the perhaps the phenotype, what is the prognosis, and how do the guidelines match the trial evidence to the phenotype. And yes, I do get this question about how about other parameters that are more specific for contractile performance. Yes, the strain is definitely a better load-independent assessment, or maybe end-systolic pressure to volume curves in the cath lab may be a much more specific way to assess contractile performance, but we don't have this widely available. And keep in mind, we still need to reassess the EF for the devices, and EF by itself is never, by the clinicians, used in isolation. You look at the volumes, you look at the wall thickness, you look at other etiologies. In the definitions, in the guidelines, for mildly reduced and preserved, we actually recommend the second bullet to ascertain the diagnosis of heart failure. What does the second bullet say? Elevated filling pressures. So just by having a mildly reduced EF is not adequate for heart failure diagnosis. For you to say this is heart failure is a syndrome, it has symptom signs, attribution to heart, and corroborated by these elevated filling pressures, especially for mildly reduced NPEF, because they do have mimickers. And in the guidelines, we do have Now, step-wide approach for phenotypes. So this is HFrEF. The first column is step 1. What does step 1 say? Quadruple therapy with beta blockers, mineralocorticoid receptor antagonists, now sodium glucose cotransporter 2 inhibitors, and renin-angiotensin inhibition with either angiotensin receptor neprilysin inhibition, ARNI, sacubitril valsartan, in only NYHA class 2 to 3, because there's no evidence in NYHA class 4, or ACE inhibitors in NYHA class 2 to 4, and if ACE intolerant and can't use ARNI, you can use ARB. So that's 4 classes of medications as step 1. We say you can initiate either 4 at the same time, which is rare in those individuals who may be lucky enough to tolerate initiation of 4 pills at the same time, or you can sequence, not according to the historical sequence of the clinical trials, but according to the specific etiologies and indications and phenotypes, as long as you do this quickly. Remember, the separations of curves happen early, within a month. We can't wait. I make this similarity to induction chemotherapy in cancer. You can't wait 6 months to optimize GDMT. So optimize, regardless of which one you start with, consider the add-on. You can start 3 meds and add 1. You can start 2 meds and add 2. You can start 1 and add the others, but try to do this in an expedited manner. You can do it with 1-week follow-up. You can do it with telehealth. You can give the prescription to patients if they are able to tolerate it and do a sliding scale like we do with many other medications. So all of these permutations can be done by the clinician according to clinical indications, access to the system, your system's setup as to Mount Sinai or others, whatever the setup is, you could do it with telehealth. The second step is up titrated doses of the quadruple as much as tolerated. So the dose is important. Why does the dose matter? There is evidence of reversal of remodeling with these new agents as well as the old agents, such as beta blockade. And if you look at ARNI on the left side and SGLT2 inhibition on the right side, these were modest doses, not little doses. But there's a very recent study that just got published in JACC last week, showing that even the modest doses or small doses with ARNI is as effective for reversal of remodeling from the approved HF trial. But anyway, try to achieve as much as you can to the trial doses because, look, almost 12 months. How long are you going to wait before the devices? Not too long, because there's definitely sudden cardiac death risk, but not too short. ESC guidelines say 3 months. In the US guidelines, we did not specify a time frame, and we said individualize. So the second step is optimize doses, reassess EF. If low, hydralazine nitrates indicated as a class 1 in self-declared African-American or Black patients, and then comes the devices and add-on therapies. And our device guidelines recommendations have not changed. Left bundle, QRS more than 150 is a class 1 indication for CRTD. We just heard about his bundle pacing, which is rapidly evolving in heart failure. Other class 2 indications with the permutations as shown on this slide, depending on whether it's a left or a non-left bundle and a QRS width. Add-on therapies beyond the standard quadruple therapy that I just mentioned. Remember that 4 other agents that are listed include vericiguat as a class 2B, digoxin as a 2B, potassium binders as a 2B in HFrEF, and ivabradine as a 2A for those individuals with symptomatic heart failure with a heart rate exceeding that of 70 despite optimal dose of beta blockade. Why am I showing this slide? These are only indicated in reduced EF. Reduced EF add-on to the quadruple. So reduced EF has more armamentarium, more ammunition as an add-on. And we also have additional therapies such as revascularization, which we just heard about, or MitraClip, right? Edge-to-edge mitral valve repair in a certain EF specification. This is the COAP trial criteria, EF 20 to 50%, a certain volume, and a PA pressure. So EF matters for these therapies. And keep in mind, only after optimization of GDMT is when the MitraClip needs to be considered. And very quickly, mildly reduced EF indications due to the trial results that I showed you includes SGLT2 inhibition as a higher level of recommendation. When we wrote the guidelines, we only had one trial, therefore SGLT2 inhibition is a 2A. But keep in mind the standard methodology, if there are 2 or more large-scale trials, it's usually a class 1 indication. When we wrote the guidelines, we had only one trial. So SGLT2 inhibition 2A, all others for mildly reduced, including beta blockade, because beta blockers are indicated by meta-analysis in mildly reduced, as well as ARNI and MRA and ARB as 2B. PEF SGLT2 inhibitors as 2A recommendation, and only the 3, ARNI, MRA, and ARB as 2B. No beta blockade here. And improved EF, one trial told us if you withdrew treatment among individuals who become asymptomatic after treatment and normalize their LV, if you withdraw treatment, a significant proportion will relapse. What does this mean? Their EF improvement and resolution of symptoms may suggest remission rather than total cure. Therefore, in the guidelines, we say those who improve, continue the GDMT, don't stop it, unless you know it's a curable cause. And yes, we do have recommendations, treat specific etiology. The group listed on the right side has specific recommendations, not just that quadruple therapy or the others that I have shown. Amyloid has its own recommendations. You can't treat amyloid with that armamentarium I just mentioned to you. You can't give digoxin to amyloid. You can't do beta blockade safely in amyloid. So in essence, all these entities, which you all know really well, require specific treatment strategies. And in summary, in reduced EF, we recommend quadruple therapy with ARNI or ACE inhibitor or ARB, SGLT2 inhibition, beta blocker, and MRA. We say quadruple because there are 4 classes as step 1, and it's a class 1. For mildly reduced and preserved, sodium glucose cotransporter 2 inhibition has 2A, and the others are 2B. And for improved EF, we recommend the treatment to be continued. So I'm hoping that I answered the question about EF and would like all of us to embrace these evolving new strategies with targeted approaches to etiology and patient's journey rather than just one feature in their phenotypic classification. Thank you.